I think the secretary of
Finish up with the ear.
all of them.
And then move into the shoulder axillary region. You have a whole bunch of different parts to the ear. The external ear, which is also called the peanut. The little knot here in the front is the tragus. The antitragus is the bump back here in the back. The arch here is the helix, and the arch in front of it is the antihelix. Of course, this is the lobe that may or may not be attached depending on your genetic predisposition. The other areas I don't think are really that important, but the reason I bring those up is they're common sites of piercings, and a lot of times you have to deal with infections related to piercings. So whether they go through the tragus, the antitragus, the helix, antihelix, you have to deal with it. And the first way you deal with an infected ear is you take the piercing appliance out. There's no question about it. I don't care how much you paid for it. I don't care what it looks like. It has to come out. Once you get an infected appliance, it's almost impossible to get rid of that infection until you remove the appliance. That includes a piercing. That includes an artificial knee. So there you go. Any questions? Okay. Understand that underneath the skin you have cartilage. And cartilage is not well vascularized. You often see people with, especially wrestlers, MMA fighters, those types of folks who get a lot of trauma to the ears. Blood that occurs in the subcutaneous space between the ear, between the skin and the cartilage will cause a deformity in the cartilage and in the subcutaneous tissue that you can't get rid of. And so their ear looks all puffy, looks like a cauliflower, hence its name, cauliflower ear. You can Google that, Google images, and you can, they're all over the place. The pathway of sound transmission, first you have sound traveling through air, and that's going to go down the external canal to strike the tympanic membrane. The tympanic membrane will vibrate related to that sound, and connected to the membrane is a small bone, one of the three ossicles. So these three ossicles are connected in the chain. So the vibrating tympanic membrane sets up vibration along these three bones in series. The most medial bone is connected to a structure called an oval window. That oval window is a membrane that sends the vibrations into the cochlea. The cochlea is a spiral, like a snail shell, and there are two sides of it. So the vibration goes up one side, crosses the point, and then comes back down the other side, where it dissipates into a structure called the round window. There's no bone attached to the round window. So when you are dealing with hearing loss can either be conductive. In other words, there's something wrong with the vibratory mechanism from the tympanic membrane through the three bones into the oval window. A conductive hearing loss versus a neural hearing loss or sensory neural hearing loss, that would be involvement of the cochlear part of the eighth cranial nerve, the vestibulocochlear nerve. The cochlear nerve innervates these cells all along this spiral. So depending on the frequency, as the vibration goes through that cochlea, it is picked up by cells somewhere along that spiral and transmitted, the information is transmitted to the brainstem. Now, remember the first day when we were talking about nerves, I said that there are two places where you find bipolar nerves, the auditory system and the olfactory system. Those nerves up in the respiratory mucosa, the olfactory mucosa are bipolar. These guys are bipolar too, the cells of the cochlea. And you see that that's a spiral. The ganglion that houses those sensory neurons is called the spiral ganglion. It sits in the middle of the spiral cochlea.
So this is bipolar, and what else is bipolar?
Olfactory. Okay. The other part of the, so this is the external ear from the tympanic membrane out. The middle ear is behind the tympanic membrane where the ossicles are. And the inner ear is from the round window and oval window internally. So the cochlea is part of the inner ear as well as the nerve. There's another part of the inner ear, it's called connected with balance. And that's the vestibular portion. And there are 5 portions to that. There are 3 semicircular canals that are oriented in different planes. And then there's a thing called the utricle and the saccule. Those 2 little structures there. The utricle and saccule are kind of responsible for linear acceleration and deceleration. And the way those things work is can I see your water bottle? All of these structures are filled with fluid. So when you have acceleration, you see what happened to the fluid? It moved. And then when you have deceleration, it moves again. So that movement of fluid in the utricle and saccule stimulates your vestibular neurons to fire. It tells you how fast you're going or decelerating. The semicircular canals are in 3 different planes, like an XYZ axis. And they too are filled with fluid. So they inform your head of the position of your head in space. The orientation of your head in space. Or not only just sitting there, but you combine momentum with orientation, and that means that any way you move your head, you're able to, because of the fluid shifts in those structures, are able to know where you are, where your head is in space. Interestingly, the 8th cranial nerve is connected to 3, 4, and 6. So that's why, which goes to your extraocular eye movement muscles. That's why I can look at you, I can look right there at your eyeballs, right there, and I can maintain that gaze on your eyeballs no matter where my head is in space. Right? It's a nice reflex. Now, one of the things you want to do when you get home tonight to your cat or something is to, so if I take and I turn my head that way, then what happens is the fluid essentially stays still and I shift the cells, the sensory cells, right? So they're stimulated by the movement of the cells against the fluid. So I know I'm looking to the left. However, if I keep looking to the left and rotating like this, I will eventually get the fluid rotating too, right? But when I stop, my head is going to think that I'm still going to the left, so what's it going to do? My eyes are going to keep going to the left until the fluid stops spinning. So that's kind of a cool trick you can do, not to your cat, but to your significant other or non-significant other.
So what causes like when you get sick and you're dizzy, is that related to that fluid?
It can be a whole bunch of different things. Like seasickness is the constant motion of that fluid that the vestibular nerve is also connected to the vagus nerve, which is responsible for you throwing up. So that's why you get the sour stomach, is the vagus nerve. You can get infection in here. This is called labyrinthitis. You can get an inflammatory process in here. It's not infectious. That's called Meniere's disease. So there you get all sorts of conditions related to the inner ear that will affect balance. And one of the cool things I like to do is, so you know the eustachian tube right here opens the middle ear to the back of the nasal cavity, right? Because you can pop your eardrum because you put pressure on your, right? You understand what I'm talking about? So when you have a cold and you get all this nasal congestion, your swelling down here, it blocks that tube. And that's why the ear will try to equalize the pressure by filling up with fluid. So that's the pressure you feel in your ear from a cold, right? So if a person has fluid in one side of the ear, it puts pressure on these structures here, including the windows or the apparatus of the inner ear, okay? So what you can do is, because the inner ear controls balance, if a person has fluid, and this is just what I've found messing with people, if they have unilateral fluid and their eardrum is bulging because of the fluid, they got a lot of pressure and pain, if you get them to walk towards you and close their eyes, they will fall to the side of the fluid. It's the oddest thing. I don't know if it's real, but I've had several people do that.
What is the correlation with the anatomy of the ear and like when you're intoxicated and you feel dizzy or sick?
That's a central effect.
Okay.
Yeah. That's a central effect.
So mine too.
That's affecting your nervous system otherwise. Okay? Okay? Yes, ma'am.
The bipolar neurons in the first day you mentioned it wasn't nose, it was eyes. Is it all three? Is it eyes, nose, and ear?
Actually, the eyes are not. It's the nose. I misspoke.
Okay.
Okay. Okay, any other questions about this? Thank you. This is another illustration showing that the middle and inner ears here are within the petrous portion of the temporal bone. That from the middle cranial fossa, it goes up to form that ridge and back down. That is where you'll find the middle and inner ears. And another thing I want to show you on this slide right here is that the tympanic membrane is not straight up and down. It's at a very sharp angle in your ear canal. It's not straight up and down, it's at an angle that's evident on this picture here. Okay? Here's another illustration of it in the petrous portion of the temporal bone. The other thing here with this illustration though is cranial nerve 7 has been attached, or put in here. 7 and 8 go through the internal auditory meatus. 8 is going to these structures. 7 goes in, up and around, there's the 7th cranial nerve, and then out the stylomastoid foramen. So 7 is intimately associated with the petrous portion of the temporal bone. One other thing I failed to mention this morning that you should all be aware of is that the thinnest part of your skull is right here on the temporal bone, right here, which is where the middle meningeal artery is. So that's another thing about getting whacked in the side of the head is that's why the middle meningeal artery is so close to being commonly cut. Okay. Here's another stylized version showing the connection of the one of the ossicles to the eardrum. I have ossicles over in the lab that have been removed from a cadaver that you can see them. You know, the lay person, the hammer, the anvil, and the stirrup are there. The real grown-up terms would be the malleus, the incus, and the stapes. The malleus connects to the tympanic membrane. That long thing right there is called the long handle of the malleus. You need to know that term. It articulates with the malleus articulates with the incus. The incus articulates with the stapes. And the foot plate of the stapes you see is oval. That's why you know that the foot plate is attached to the oval window of the ganglion, of the cochlea. Okay. Here it is in a more stylized version, showing the relationship of cranial nerve 7 coming out of the brainstem, going up and over and down out the stylomastoid foramen. It gives a branch off that you know that you can actually see on some people's, through the tympanic membrane of some people, that little branch that resides in the middle ear is the chorda tympani. It branches off of the root of 7, runs across the ossicles, and exits the middle ear to come down into this area right here where it would join the lingual nerve. That's the chorda tympani. All right, that's kind of interesting. There is also another nerve that, you know, on that slide before that showed all those connections, the circuitry, I said read over it, but don't spend a great deal of time. One of the nerves that's prominent in there regarding cranial nerve 7 is the greater petrosal nerve. The greater petrosal nerve exits the 7th cranial nerve in the petrous portion of the temporal bone. That's where it is right there. And that nerve right there contains the visceral efferents going to your nose and to the lacrimal gland. All right. Here's the spiral ganglion here that you see. And here's the innervation of the vestibular portion. That bipolar containing ganglion is called the vestibular ganglion.
So these small structures like this in the ear, how would you ask questions on an exam about them? Like what would you, obviously tympanic membrane or something
They would be more general questions rather than all of the specific detail you see on these slides. The things that I'm saying, that's what's going to be on the exam. I'm not getting into all of these other pieces and parts. Just, you ought to know what the spiral ganglion is. You ought to know what the vestibular ganglion is, what they go to, what type of information they carry, because this is clinically relevant. Okay. This illustration is to show you the eustachian tube or the auditory tube and how it penetrates through the base of the skull. And actually, we're going to pick it up later when I bisect the head tomorrow. You'll see the opening of the auditory tube inside the wall, the posterior wall of the nasal cavity. It's pretty impressive. And remember though, a lot of the time, a lot of the ear problems that you see with colds, with the pressure and decreased hearing, the dizziness, it's not the ear. The problem is the mucous membranes inside the nose, and that's why you want to use a decongestant or nasal steroid to open up the auditory tube so your middle ears can drain. Right? This is an image of the tympanic membrane. It's not called the eardrum anymore. It's called the TM, or the tympanic membrane. You can see the long handle of the malleus attached to the back side of it there. This is the malleus up here, the body of the malleus. It creates two parts. This part is called the pars flaccata. The rest of the part here is called the pars tensa. And it is tense, it is tight. It has to be to transmit vibration. Because it's at an angle in your ear canal, it produces a reflection back at you if you shine a light on it. That reflection is called the cone of light. And it's there, it's always there. When it's not there, it means that it's something behind the eardrum is distorting the drum itself. I call it eardrum, the tympanic membrane. Something is behind the TM distorting it, like pressure or fluid. So in your analysis or your physical examination, you make a statement about when you look in the ears, you would say the canals are patent, TM is visualized, it appears intact, cone of light is evident. That tells you that's a normal ear. There are two little muscles in the middle ear. There is the tensor tympani, which rises from a bone, is a bone, and inserts into the tympanic membrane, to the malleus. And then there's the stapedius, which is the smallest muscle in the body. It arises from the bone and attaches to the stapes. Now what these things do is they contract to dampen sound, to prevent or decrease damage to your cochlea.
Stapes, what's the other one over there?
Tensor tympani. The tensor tympani is innervated by 5. Stapedius is innervated by 7. Bell's palsy affects cranial nerve 7, right? Because it wind up with a droopy face. So in addition to a droopy face, what other things you think are going to happen with the 7th cranial nerve not working? This thing doesn't work. The stapedius muscle doesn't work anymore. So sound, what is the function of the stapedius? To dampen sound. What does the person with Bell's palsy complain of? Hyperacusis. Loud, everything's loud because the stapedius doesn't work. What does 7 also supply? What? What does 7 also supply? Muscles of facial expression, we got that, because that's how you know they got Bell's palsy.
With the gland.
What? The glands. Decreased salivary glands, they're dry mouth. And the most significant is the lacrimal gland, they have dry eyes. And they can wind up with corneal abrasions. That's why a person with, you diagnose with Bell's palsy, before they leave your clinic, you write them a prescription for artificial tears. Or instruct them on the use of artificial tears. They need to be putting drops in their eye all the time. Any questions about that? The other thing about Bell's palsy, you're missing one other thing that cranial nerve 7 does through the chorda tympani. Chorda tympani does the glands, submandibular. What else does it do? Taste of the anterior tooth. They lose taste on that side of the tongue. They'll tell you something's wrong with the way food tastes, and that's why. See, now you're brilliant. You know all these things. So when you stop Dr. Ingo Bretson in the hallway, you can say, hey, let me ask you some questions.
I was staring at him hard.
Okay? Here are the ossicles right here. They're pretty little things. Obviously, the stapes is the smallest bone in the body. Again, I'll have examples you can look at over in the lab. I think I put them in the lab. I couldn't find them in my office, so I think they're in the lab. I hope they are. You don't need to know the pieces and parts of the ossicles, just that there are 3 and the names. Here's a picture of the chorda tympani crossing the middle ear. It's pretty impressive. So on the back side, if you were looking this way, you could, and some people see that little nerve crossing on the other side of the tympanic nerve. Another thing I want to let you know about is the proximity of the internal carotid to the internal ear. That's why a lot of times when you put your head down, you can hear your pulse. Boom, boom. That's because you're picking it up, the vibration of your internal carotid, your heartbeat through your conductive mechanisms of your middle ear. Any questions about the ear? Yes, sir.
So,
Like an ear infection, that just happens when water gets past the tympanic membrane?
The tympanic, water will nothing will get past the tympanic membrane if it's intact, which it is most of the time. Most of the time, infections, so you can either have infection of the outer ear or the canal. Most of the time that occurs with an overgrowth of Pseudomonas from swimming too much, that's swimmer's ear. Now, that's not counting the cellulitis you can get from piercings and things, but infection of the canal is usually swimmer's ear. On the inside, deep to the tympanic membrane, the infection usually gets there because when you have a cold, and I said it fills up with fluid, if you sneeze, that the ostia, the opening of the eustachian tube in the back of your nose, can open for a split second, and all the bugs that you have in your nose can inoculate that fluid, and now you wind up with infected fluid, and that's otitis media. Okay?
Because as I understand it, I was born with like a hole in my tympanic membrane, that's
Uh-huh.
and so they went and like cut a piece of skin above my ear and patched it. So I used to get like, every time I go swimming, I'd have an ear infection in my left ear, like when I was a little kid. So,
And was that infection of the outer ear or the middle ear?
I'm not positive, I was really middle. I wanna say, I thought it was the middle ear, but,
Well, hopefully they patched up the hole, and it
yeah, they did.
wasn't. You know, if the pressure gets so bad, it can really get painful. You know how painful it is if you have a cold and your ears are stopped up and you get on a plane and you start, that really is painful. A lot of times though, when it ruptures because of the pressure, the pain goes away because now the pressure is on the TM.
So you said with Bell's palsy, you have a lot of loud sound. What causes your ear not to hear when you hear really softly? You can't hear too good.
When you get older, it's called presbycusis. And presbycusis, like I have, is when you're hard of hearing. And it has to do more with destruction of the receptor cells inside the cochlea. Too much loud rock and roll, too much loud, people who work in factories or around guns and things like that. The more loud sounds you're around, the worse you're treating your cochlear cells, which really is an issue with me because you see everybody with earbuds in. That is amplifying sound tremendously versus listening to it without earbuds. I think you people are going to wind up with presbycusis to a much greater extent than us people who invented those things will. You didn't catch that. You little young people, you smart ass, look at all the electronics I got. But who do you think invented them? It's us, not you. Mark Zuckerberg, he didn't invent anything but a little software. I mean, Facebook, what is that? Sorry, go ahead.
That's it, that's all I had.
Oh, there's Mason.
Was hard of hearing. No, I'm not hard of hearing. What was my question?
I have a question.
I know, but I had to carry it to the extreme. Yeah, you got me started on a roll.
So when your tympanic membrane bursts, can you see the light, or is that like whenever, like if you,
If the tympanic membrane bursts, you can see the hole. It's pretty easy to see a ruptured TM. The light, the cone of light may be there still.
okay,
The cone of light goes away if the eardrum is bulging because of pressure behind it.
okay.
Okay. Anything else? Yes, sir.
Tubes are put in kids that have recurrent infections, and I know this practically, but how does that relate to the pressures we've talked about? Where on the structures do we have those tubes placed?
Yeah. Myringotomy tubes is the name. your myringotomy. What they do, it's an office procedure actually. The ENTs go in and make a little slit in the tympanic membrane, in the pars tensa part, and they put a little tube through the tympanic membrane. You don't suture it in or glue it in or anything. It stays there. A lot of people will eject the tubes over a period of a few months, but some kids, it'll stay in there for a couple of years. And what that does is, in kids that get frequent ear infections, and the reason kids get frequent ear infections, there are a bunch of reasons. One is their heads are different shaped than ours. Their tympanic membranes are more flat. So the thought is that bugs can crawl up that more flat eustachian tube versus ours that are more angular like that. The other thing is that parents put kids to bed with formula or milk or whatever, and with a bottle, and sucking on that bottle, the fluids eventually, as they go to sleep, can get up in there into TM, infect, and stuff like that. So what you try to do is kids that get frequent ear infections is you put a tube in there to keep the pressure from ever building up. Okay. Kids they frequently get pressure in their ear. They're very irritable. They keep you up all night. It's a miserable experience, not only for them, but for you. And it's very frequent. So, over the next 2 days in the morning, we're going to finish up the head and neck, but now we're going to talk about what we're going to dissect this afternoon, and that is we're going to go into the upper extremity, to the shoulder and axillary region. There are huge differences between the upper extremity and lower extremity in terms of mass, in terms of the anatomy, being able to provide greater weight or hold greater weight versus have greater mobility and dexterity. You can do this with your fingers. You can't do that with your toes. You can do that with your arm. You can circumduct your arm, but you can't circumduct your hip. The bones in the lower extremity obviously are much larger than they are in the upper extremity, as well as the muscle masses. The different regions that we deal with here are the pectoral region in the front. You've got the axilla, which is the area bounded by the anterior axillary fold and the posterior axillary fold. So this is the axilla. You have the shoulder, which is the deltoid region here. Then you have the arm, elbow. This is also called the cubital fossa. Cubital fossa, the elbow, the flexor surface of your elbow, called the cubital fossa. And you have the forearm, wrist, and hand. The dermatomes we've talked about. You have C4 up here, and then 5, 6, 7, 8, P1 are your upper extremity. You hold your hands out like that. 5, 6, 7, 8, T1. T1's in here, C5's up here. It's very easy. You want to do it again? Mm-hmm. So we know C4 is right here. C5, 6, 7, 8, T1. Just like the thing says it. Okay? Very easy. And it's like this, thumb up, not thumb down. Thumb up. Because when you were a little bitty rodent before you evolved, your upper extremities and your lower extremities were the same. But as you evolved, your upper extremities rotated as a fetus, or really as an embryo. Because when you started out, your upper extremities were rotated inward like that, just like your toes, just like your feet are. As you evolved, as you developed in utero, they rotated out and rotated around like that. Now, if you look like a cat or a dog, they have a scapula, they have a humerus, and a forearm just like you do. Theirs didn't rotate though. Yours did. Some of you did. Okay? Gosh, man, you guys are too tight, that was a joke. All right, the bones of the area here, I don't need to go over the pieces and parts of the bones. You can memorize those yourself. Very easy. You really ought to know all these areas, though. They're highlighted in the next 3 slides. There's one articulation in the upper extremity. There's only one articulation in the upper extremity, and that is the connection of the clavicle to the sternum. Everything else is essentially free-floating. Okay? When you stop and think about that in a minute, that's going to be pretty impressive. There's really only one attachment to the upper extremity, bony attachment, and that's the medial head of the clavicle. All right, the humerus, I want to identify a couple of things here. There are 2 tubercles. There's a greater tubercle and a lesser tubercle. The greater tubercle, if you're sitting there right there, the greater tubercle is that point right here on the lateral side. The acromioclavicular joint's on top. That point is the greater tubercle. Feel that right there, the greater tubercle. All right, that's the greater tubercle. The reason I want you to know that is because if you're going to put an intraosseous needle in, it's a needle that goes directly into bone for infusing fluids. That is the second preferred site to insert it right there at the greater tubercle. Okay, so you'll need to know that location. Greater tubercle. Y'all cut it out. Go get them home. All right. There's a lesser tubercle also that you really can't palpate. And in the middle of the tube, there's an intertubercular groove that's going to transmit a tendon. So there's a greater and lesser tubercle and an intertubercular groove in the humerus. There's also a thing called a spiral groove on the shaft of the humerus. The spiral groove transmits, is formed by the passage of the radial nerve. I'll bring this up later. The other thing is with the humerus, there's a difference between the anatomical neck and the surgical neck. This is, of course, the head. The articular surface is the head. And in that right there is the anatomical neck of the humerus. Anatomical neck. Then you've got the tubercles. And below the tubercles, right there is the surgical neck. The reason I say that's the surgical neck is because that's where humeral fractures occur. They don't occur at the anatomical neck. You're going to break your humerus, you're going to break your proximal humerus, it's going to be through the surgical neck. The anatomical neck really has little clinical relevance. It's the surgical neck that does. If you look at the radius and ulna, knowing the pieces and parts, they are connected by a thick fascia called the interosseous membrane. The bones of your leg down here, the fibula and tibia, also have an interosseous membrane similar to those two. The head of the radius is right there. It has a tubercle below it for attachment of the biceps. And then there's an articular surface of the ulna. If we go back one, right here, there's a capitula and a trochlea. The articular surfaces of the humerus with the radius and ulna. I always remember, you know what RC cola is? RC cola? The radius capitulum. That's how I remember which one articulates with which. The ulna would articulate with the trochlea. RC cola. It works for me, it may not work for you.
Say that again? Say the RC cola thing again?
RC colon. Radius articulates with the capitulum. That's the capitulum right there. That's surface. The areas, by the way, above the articular surface there are called the epicondyles. The epicondyles are sites of attachment or origin of either the flexors or the extensors of the wrist and fingers. That point will become important tomorrow. The epicondyles are sites of origin for the muscles of the flexors and extensors of the wrist and fingers. At the end of the radius and ulna, there's a little prominence. See the little prominence there? That's called the styloid process. You have a radial and an ulnar styloid process. You can feel them quite easily. Those are the two styloid processes right there on your wrist. If you'll notice, if you put your finger on the styloid process, the radial styloid process is about 1 centimeter longer or more distal than the ulnar styloid. Okay, those are the styloid processes. If you look at the articulation here, the glenoid is the flat or the slightly concave depression on the scapula for articulation of the humeral head, the glenoid cavity. If you look at the articulations here from above, the scapula is free floating on your back chest wall, held in place by muscles. Here's the only bony attachment. The rest of the attachments here are all ligamentous and muscular. There are tons of ligaments that hold these guys together. I don't really care that you know the ligaments. I don't think it's really that significant for us at this point. You can see that they are quite numerous in here. As long as you understand and appreciate that there are ligaments between all of the different bony prominences of the shoulder. Probably the one that's really of clinical relevance, though, is the connection between the acromion and the clavicle, the AC joint, the acromioclavicular joint. The rest of them, they can be torn, stretched, but you really don't do much with them. It's the AC joint that you really pay the most attention to. Now, joints of the limbs, upper and lower extremities, are surrounded by a capsule. And that's what this is intended to show. It's a capsule that keeps the articular surfaces isolated from the rest of the body. There will be a few milliliters of fluid inside that capsule that when we see it down in the lab, it's like, has sort of the consistency of Karo syrup. It's sort of thick and clear, clearish yellow. That's the synovial fluid that you normally have in all synovial type joints, even the small joints in your fingers. Here's the greater and lesser tubercle. There's the intertrabecular groove with the tendon of the long head of the biceps running through it. Here's an example of AC joint separation. There are different degrees of separation based on how extensive it is. You can see up here at the top X-ray the normal distance between the clavicle and the acromion. Down here you can see that the ligaments obviously have been disrupted and they're moved apart. Most of the time, one this severe will probably require a little bit of surgery to connect point A to point B. If it's just a partial tear or slight malalignment, you can usually get by with physical therapy, rest, and that sort of thing. But this one's probably going to need some work. Any questions about that? Fracture of the clavicle. The clavicle is the most commonly fractured bone in the body. The middle third of the clavicle is what is fractured the most. As you see here, 80% of the time, it's the middle third. And it's probably because the two ends are tethered. And the thinnest part of the clavicle is the middle part. It's mostly, if it's fractured, a lot of times people won't even know it. And you'll notice that there's a bump up here when you see somebody with a low cut thing, not that yours is low cut, but you see her clavicle right there? There's a clavicle. You'll notice a bump right there in the middle third. I actually have one. I didn't know until I was a a PA student, the person that we were practicing physical exams, said, hey, you've had your clavicle fracture. And I didn't remember it. It must have happened during high school football or something. I never knew it. But I have a bump on, I can't remember what side now, on my clavicle. They're asymmetric. So it's interesting. You watch TV now, and you sit there and you'd be surprised at how many people you're going to see now with that bump. Oh, look, that actor has had his clavicle fracture. Okay? It usually always produces a bump. In a kid, though, the bump, it doesn't.
If it's off the head, is it like, do they lose function of their arm at all? Like, isn't it really painful?
Yeah, if it's a complete tear, disruption down here, it's probably going to be a surgical case. Oh, here's a surgical case right here, where they go in and put a plate with screws to bring it back together. Most of the time, though, if a clavicle can break, and as long as it's not overlapped by more than ½ an inch, you can usually just do nothing, and it'll heal on its own. They used to put people in what are called figure-8 splints that wrap around and under your arms and kind of pull you back like that, but they don't do that now. That's not the treatment for a clavicle fracture.
Do they still put them in a sling? Like, my friend's son broke his the other day.
Yeah, you put it in a sling.
Yeah.
You don't put them in a figure-8. And of course, you gotta just stay away from contact sports and things like that until it heals. Who was that? Is it Tony Romo? They had a fracture of clavicle. You know, they waited. He was out, what, 2 months, and they let him go back and play football.
And again.
And he broke it again. So anyway,
Well, he's really nice.
it's pretty easy. It's pretty easy to fracture a clavicle. And you see the clavicle fracture. Okay. There are also ligaments that hold the humerus onto the glenoid cavity. They're called glenohumeral ligaments. They're very strong anteriorly, superior, and posteriorly, but weak inferiorly. The glenohumeral ligaments are weakest inferiorly. You'll also see that that's where the muscles of the rotator cuff are strongest, anterior, superior, and posterior, weakest again inferiorly. That's why most shoulder dislocations occur in an anterior, inferior direction. They come out the bottom. Yes, ma'am?
So is the entire thing called your rotator cuff, all the ligaments together?
No, these are not part of the rotator cuff. It's only the 4 muscles that are part of the rotator cuff. These are the first, so when you're talking about the joint itself, first you have a capsule. Then you have the ligaments that are surrounding the capsule, and then you've got all the tendons and muscles over top of the ligaments. And all of those things contribute to the stability of a joint. The one thing I did not put in any of these slides is that if this is the glenoid cavity here, like that, it is a shallow concave thing. There's a piece of cartilage that's like a disc, a flattened disc, that is on the edge of that, runs around the edge of that cavity. If we look at the glenoid cavity like that, that cartilage runs around the edge like that, and it's shaped like if you were to do it in cross-section, the cartilage is shaped like that. So what it does is it decreases, if that's the humerus, it decreases the depth of the surface here. You understand? You follow me? You don't follow me? So, if this is the glenoid from the side, and this is the glenoid facing it, around the edge, it's not in the middle, it's only around the edge. There's a thing, piece of cartilage that's shaped like that. So it's like that around there. And what it does is it deepens, this would be the glenoid right there. It deepens the glenoid cavity. That thing is called the labrum, glenoid labrum. because it's cartilage, it doesn't show up on x-ray. And this thing can be torn, and most likely will be torn in shoulder dislocations. The glenoid labrum. So when they have to do arthroscopic surgery, they usually have to go in and clean up the labrum. Is that what you had done?
Yeah, I have anchors in the back. I had anterior and posterior all the way through chairs.
Yeah, you're ugly. Okay? All right, any questions about that? This is a shoulder dislocation. You see there's the glenoid up there, the head of the humerus down there. This is supposed to be up there. So reducing a shoulder is a pretty easy thing to do. Again, you need some good sedation because the surrounding muscles are pretty well tightened down. When it goes back into place, though, it is a clunk. It makes a loud, it feels like, oh, that hurt. But actually, it feels better. All right, so the muscles in the region. The pectoral muscles, you have two muscles. Pec major, which arises from the sternum and the ribs and inserts over into the humerus. And you have the pec minor, which arises from, is underneath it, deep to it, arises from ribs like 3, 4, 5, inserts into the coracoid process of the scapula. Out here you see the bicep muscles that we'll deal with tomorrow afternoon. The deltoid up there is a pretty healthy muscle. It arises from essentially 3 different places, the scapula all the way up to the clavicle, and comes down and inserts into the deltoid tubercle, which is that prominence you feel right there on the humerus. The deltoid, because it arises from both the front and the back of the shoulder, is responsible for not only abducting, abducting, it also can pull it forward or pull it backward, depending on which fibers contract. So basically, though, the deltoid is a strong abductor of the upper extremity. Pectoralis muscles, you understand, are going to be responsible for, because the pec minor inserts on the coracoid process, it helps move the scapula forwards. The pec major is out here on the humerus. It's going to be responsible for adducting, or bringing it towards the midline, as well as the rotation. Here are the rotator cuff muscles. They're abbreviated SITS, S-I-T-S. There's a supraspinatus, the infraspinatus. They both be inserted over here onto the humeral head. You have the teres minor, not the teres major, teres minor. Teres major inserts down here lower on the humerus, so it doesn't have anything to do with the shoulder articulation itself. These guys are going to help laterally rotate the upper extremity, right? They laterally rotate it. The last muscle of the rotator cuff is the subscapularis. It inserts medially. It is a medial rotator. It's underneath the scapula. It's a medial rotator. Again, the weak area here, just like the ligaments, is inferior. All right, here's the innervation of the different muscles up there to just give you some sense of they're in a dermatomal, myotomal pattern from seat. Well, they have the cervical muscles there as well. The cervical area on through the brachial plexus and so on. So you're not responsible for knowing which segments give rise to the nerves going to which muscles, okay? Later on, I'll point out specific nerves that go to muscles. You need to know those, but this is just for illustration purposes. Now, this is the brachial plexus. Comes off of C5, 6, 7, 8, T1. The big artery runs between these large roots. You'll find those, the brachial plexus, in the axilla. So that's why we're going to dissect this out today. Before we get to that, here's a summary slide showing the muscles, the innervation, and their main actions. Okay? You might want to have some appreciation of this without knowing specifics. Protract the scapula and rotate. That's fine. If you know that it protracts the scapula, that's good enough. Okay? Just a general function. All right? And I'm going to identify the specific nerves and muscles I want you to know. Before we get to the brachial plexus, the blood supply to the upper extremity, we know about the subclavian. The subclavian will continue as the axillary. The axillary will continue as the brachial artery. The brachial artery divides down here somewhere in the elbow region. Some people it's above, some people it's below, into a radial, which you can feel the pulse there, and an ulnar, which is you have a pulse on the other side. The radial and the ulnar artery are in your wrist. That's where you feel that. You can feel the brachial pulse right here above the medial epicondyle. That's where you put your stethoscope when you're taking a blood pressure. You don't put it in the cubital fossa, you put it over here on the brachial artery. This is let me skip that and go to this one. This is the one I prefer you look at. There's a subclavian artery right there. Once it crosses the first rib, it now becomes the axillary. Once it crosses the teres major, it becomes the brachial. Between there and there, it gives off all these little branches. These branches are pretty easy to find because they're pretty large. Starting from the highest is the superior or the supreme thoracic. That will supply the first one or two, or help supply the first one or two intercostal spaces. Then you have a trunk that comes off there called the thoracoacromial that sends 4 little branches to the pectoral region, the deltoid region, the clavicular region, and the acromial region. You don't need to find those 4 branches, but understand that the vessels up in here are supplied by that. I mean, the structures up in here are supplied by that thoracoacromial trunk. Then you have a lateral thoracic that runs down the side of the wall here, supplying the chest wall and the muscles laterally. The largest branch is this one right here. It's the subscapular artery. The subscapular artery descends down to the back of the scapula. You'll see it, it's big. It's going to have, it continues as the thoracodorsal that will go to supply the latissimus dorsi, but gives off a branch called the circumflex scapula that will go onto the back of the scapula. And I'll show you an illustration here that will drive that point home here in just a second. So don't get worried out that you're not getting this right now. The last 2 branches are the anterior posterior humeral circumflex that come off and go around the head of the humerus for the blood supply to the head of the humerus. Anterior posterior humeral circumflex. Okay? Here's the thing that I didn't want you to get crazy off about because it explains it all. You know, back a long time ago when we were in this class, there was a thing called the thyrocervical trunk. Remember that thyrocervical trunk that gave rise to the inferior thyroid, the ascending cervical, and the transverse cervical, and the suprascapular? Remember that? The transverse cervical goes over here to supply the rhomboids and the trapezius. The suprascapular goes through that notch in the scapula. Actually, it goes over the notch to supply the supraspinatus muscle, the infraspinatus muscle. And what those are going to do is this is going to anastomose. Anastomose means to join. The suprascapular is going to join with the circumflex scapular off of the axillary. So this is off of the subclavian, right? It's going to join with this artery off the axillary. Transverse cervical is going to join with the thoracodorsal to form a collateral blood supply around the scapula. Why is that important? Well, when you're down on the south side buying drugs, you get shot right here, and you're bleeding like stink, and you have to go in and clamp off